Hello everybody, I'm Joanna Goodrich and I'm going to talk to you today about my study which explored the experience of healthcare staff who had all shadowed their patients in order to understand their experience of care better. The participants were all taking part in a collaborative quality improvement programme in end-of-life care. A bit about myself, I worked for many years at the Point of Care Foundation, but for the purposes of this study, I stepped down from this particular programme so that I could do the research. And thank you to my supervisors at the University of Westminster, Tina Cartwright and Damien Ridge.
So just a word about the Point of Care Foundation by way of background. It's a not-for-profit organisation with a mission to humanise healthcare for both patients and the staff who look after them. This is because of the strong evidence that patients' experience of care is linked so closely to staff experience at work. This is done through a number of practical interventions. There's the Schwartz Rounds programme that some of you will have heard of, but we're talking today about the Sweeney programme, which is the quality improvement programme. The key thing about the Sweeney programme is that it is patient-focused quality improvement. So the usual standard quality improvement methods are taught, but in addition, methods to help healthcare staff to understand care from their patient's point of view through the patient's eyes, if you like, are taught. So interviews, gathering patient stories, observation, and shadowing. And shadowing is different from observation. It is based on an ethnographic approach in that the member of staff will follow patients wherever they go, or sit with them if they're in bed. They would basically just be their shadow for a length of time, which might be half an hour, or it might be longer, or it might be several times at different times of day or night. And it helps them to understand the difference between work as imagined and work as done. So they may think they know the experience of their patient, but as we will see, it can be very eye-opening for them to actually shadow them. My study was to explore the process of shadowing, actually how it is done, the detail of it, what happens when staff have been trained on the programme and then they go back to their place of work and actually do the shadowing. This is detail that's often lacking in quality improvement studies which are written up, or reports that are written up. And also, how acceptable was the approach? How acceptable was doing shadowing for staff? Did they enjoy it? Did they find it difficult? What were the challenges? And to explore the impact it had on them. Because I'm interested in how it might make them more motivated to make changes for their patients. Anecdotally, we've seen that this does happen, but it hasn't been researched before. Also, to produce practical guidance for future. The participants were selected from the 19 healthcare teams who were taking part in the collaborative training programme. They were all looking after patients at end of life, but not in specialist settings, and they weren't specialist palliative care staff. They came from acute hospital wards, community and mental health trusts, nursing homes, a CCG, and a third sector organisation. 20 were selected and were interviewed either where possible face-to-face or on the telephone. One was interviewed by Skype, and there was a range of clinical and non-clinical participants: doctors, nurses, therapists, healthcare assistants, quality improvement and patient experience people, and Just to reiterate that many healthcare staff, as you probably know, do find themselves, particularly in acute hospitals, looking after patients at end of life, because so many frail older patients will be admitted to hospital and will die in hospital. And it is now a significant part of nursing and ward activity. And looking at these numbers from one of the teams on a previous cohort, you can see that there is a high number of deaths on the wards, and that they are comparable to hospices, and yet they don't receive any training in end-of-life care. So on to the results now, and I'm going to give you really just a high-level overview of what themes emerge from the data. So first of all, the feelings about shadowing beforehand. One or two people felt that they wouldn't learn anything new. They felt that they knew what the issues were, they knew their patients. I thought I know what the problems are, I know what I want to change, and so I thought, what's going to add to what I already know? What's shadowing going to add to what I already know? Others were curious. They thought it sounded like an interesting approach, or they thought it would be interesting to see actually what does happen on the wards if they were non-clinicians. They were a little bit anxious beforehand about a number of things, about being intrusive, or actually that was very closely tied up with being they didn't want to feel unwelcome. They didn't want to put anybody in a difficult position. I didn't want to be put in a difficult position. What would colleagues think they were doing? There was a fear that colleagues would think they were coming in to observe them and judge them, which was a bit awkward. And they were genuinely worried about seeing poor care. They did agree beforehand what they would do if they saw anything that they needed to report back on. So actually this wasn't a fear that actually materialised, but they had procedures in place just in case. It was interesting to see that everybody brought their own individual lens to what they saw and how they interpreted what they saw. And this was influenced by their professional background or training, their personal experience, which might have been somebody in their family or a friend in hospital or a bereavement, and simply their personality or their outlook. They also adopted different styles of shadowing, which was fine. The training had not specified one particular style, so some consciously tried to get into the zone, as they put it, and almost treated it, as one of them said, like mindfulness. Others did intervene in care. They helped the patient, or had conversations with the patients, and others saw themselves as companions, particularly where they felt that a patient didn't have any visitors themselves. The emotional response to shadowing, both during the shadowing and on reflection afterwards, fell into a number of themes. Some did respond with anger and frustration to what they saw, either on behalf of the relatives or the patients, particularly with physical things like not being able to reach call bells, or not having refreshment, or having inappropriate food brought. A very strong theme was this thing of being out of their usual role and feeling a little bit uncomfortable about that. Summed up by a senior doctor who said it just felt a little bit unusual, and this was because he wasn't doing his usual job or in his usual role. And for some, that was more difficult than for others, which led me to think about whether they had put up defences over the years to detach themselves from their patients, and this shadowing sort of broke through that detachment. Others, however, talked about very strong emotional connections with families, talking about, if that was my mum in that bed, how they would feel, or with patients, saying this was a clinician who said, I just wanted to scoop her up and take her home. Others talked about how the moment stayed with them in a way that it doesn't when they're doing their normal job, or a patient stayed with them. It goes into a part of your brain that you remember what you've seen. And others talked about a strong personal impact for them, how it made them reflect about their own mortality, or their own death or dying, or their relatives' death or dying. It was clear from the participants' accounts that their understanding or their capacity to experience what the patients were feeling had increased. But their judgment about what needed to be improved was not necessarily consistent. So, for example, some participants felt strongly that the best place to be was in a side room for patients who were at end of life. Others felt that it was more interesting and stimulating for them and less lonely to be in a bay on a ward. And this was very much down to their own personal factors that I mentioned before. So it is extremely important that they do debrief afterwards and share their experiences and reflect on what they've seen and how to interpret it. Very quickly, implications for practice. The challenges of shadowing are far more the emotional challenges than the practical, and this should be recognised. It does appear to be acceptable to staff once they do it, in spite of early anxieties. It does appear to engage and motivate them, and it can bring about, and did bring about, changes for patients and families, but it is essential to build in reflexivity to the shadowing process and to the training.
Thank you very much for listening. And if you would like any more information about shadowing or about the study or the full list of references, please do get in touch. Thank you.